Good morning, everybody. I'm going to start with something a little more on the melancholy, and that is to remember Dr. Richard Redinger, who was the chair of the Department of Medicine from 1989 to 2009. We believe, we need to fact check, but we believe that he was the longest tenured professor, chair of a Department of Medicine in the country, and certainly at the University of Louisville. He had passed away a couple of weeks ago, and we are, beginning to wrap our arms around that and what it might mean to honor him. So more of that to come. Now, on a happy note, those of you that participated in the hiker-biker activity to remember our dearly beloved Dr. Stuart Erbach, who also had passed away earlier in the year. Dr. Erbach would have been in his mid-90s, and he still taught at the School of Medicine. We had an event for him, and just to give you some preliminary data, there were over 57 hours biking and a little over 50 hours hiking, so that's over 107 hours to commemorate him. And for the biking mile total, over 742 miles biking. I don't think that the hikers kept all of their info on their numbers of miles, but that's a phenomenal tribute to him. And we raised more than $12,000, and that will go in a gift fund for the Department of Medicine Education, which is what Stuart Erbach, Dr. Erbach would have wanted that money to go to. So those are my two announcements, and then I wanted to introduce Dr. Aruni Bhatnagar. He's a Ph.D. FAHA. He is Professor of Medicine, Pharmacology and Toxicology, Physiology and Biophysics, and Biochemistry and Molecular Biology. He's the Smith and Lucille Gibson Professor of Medicine. He serves as Chief of the Division of Environmental Medicine. He is the director of the Christina Lee Brown Envirome Institute, American Heart Association Tobacco Regulation Center, as well as was honored with Distinguished University Scholar at the University of Louisville School of Medicine. And he is going to present work that he has done throughout COVID, monitoring COVID-19 using randomized testing and wastewater analysis. Aruni, you're on.
Thank you. Can you hear me and see my slides?
Yes.
Okay, thank you. Chris, thank you for the introduction, and I too want to start this presentation honoring Dr. Redinger's memory. I remember when I came here, he was the chair of medicine. He recruited me, and we spent many hours together, and he was always very supportive and very encouraging, and part of our work that we did here was possible only because of his input and his encouragement. So I wanted to talk today about our work on COVID and the things that we have been doing here, and how where can we go from here. As a disclaimer, when I and other people in our group started doing this work, we had no prior experience in working with infectious diseases, and so but there was a need, and so we actually sort of jumped in the fray and did what we could, because there was an urgent demand from people around, from our community, and there was everybody who could do anything was already too preoccupied. So we started doing this, and in the course of our work, we have learned many things, and some of which I want to share with you today. So what we did was to create a new project which we call the Co-Immunity Project. And the Co-Immunity Project was started in collaboration with the Healthcare Council CEOs, and as well as people from the University of Louisville, major leading hospitals. When the pandemic first started, we got together and said, what could we do? And so we couldn't figure out. So the first we did first was to be able to get together and discuss. And we used to have, calls on Tuesday night at 8 p.m. So that was the only time we could get everyone together and develop some sort of a strategy. We were driven in part by this rise in the threat around the world at that time, and it started as of January of 2020, and then rapidly spread, and by March the entire continent or the entire world and the globe was covered with pandemic, with the coronavirus. And it has been ever since, and we've had, last week exceeded more than 5 million, I would say, official deaths. The larger tally would be even bigger than that, but we do not know to what extent this pandemic would extract its cost. We are still in the throes of it, and hopefully we are coming or turning a corner. So as I said that members of the Christina Lee Brown Envirome Institute here at the University of Louisville and members of the Center for Predictive Medicine, we formed a team together. We did not quite know what to do, but so we had to create our own reagents, our own ELISA kits, our own test kits. We had to print our own swabs and so on to do all of this because there was nothing available. But regardless, we thought that it was something that we should and we must do. So the project was initially conceived of in 4 different phases. We thought there would be a phase 1, which was to look at healthcare workers, of course, because those are our most precious resource, and we thought that was where we should first turn to and at least ensure that we could test them. And this was very early in April 2020. And then we thought that we could keep a tab of the rates of infection, both in terms of incidence and prevalence, in the larger Jefferson County community. And then if there was some way out of this, we hope that we'll be able to start in-person exams and look at people and what type of damage the infection caused and what might be long-term consequence of COVID. And so we also then imagine that we might ultimately need a clinic of the people who survive this. So we started first with our healthcare workers, and like I said, it was important for us to do that here at UofL. We had no resources, no kits, no swabs, no PPE, but we got whatever resources we could. We marshaled our own sort of ingenuity and to come up with some ways of monitoring the rates of infection within our hospitals. And so we did 2 rounds of testing. I think one was in April last year. The next was in July. And as you can see, we did 1,300 healthcare workers the first time, around 1,000 the next time. And we found some people who were what we call RNA positive, which means that they were actually actively infected at the time of testing. And then there were others who were antibody positive, means that they were tested or they had been infected before, so that we could get both at that particular time, the incidence of the disease as well as the total prevalence that's been in our community. And then we could also tell that who was the most likely to be infected within our hospital organization. And we found that, not surprisingly, that the nurses are more likely to be infected than the physician, and followed by physician assistants. We got respiratory therapists mostly working in the ED and the ICU or the hospital floor, which had the highest risks of infection. And these findings are actually quite similar to what others have reported, although our rates of infection were actually low. So we got very low levels of infection, which would be, I would say, less than 1% of the total people we tested. So that I would think maybe 1 to 2% of our healthcare workers would be infected, but other people have reported slightly higher numbers. This is a report from the University of Washington showing that up to 5% of the people have tested positive. And certainly these were early days, and so we did not quite know how to protect ourselves, and so the healthcare workers were exposed more frequently and more inadvertently than they have since then. And so these rates have come down. But overall, this was till last year, that we could see that even in very large studies, and these are studies of about 2.6 million individual healthcare workers, about 99,000, 2 million community individuals, 99,000 healthcare workers, and they found a very high risk. This is the relative risk or hazard ratio of 11. So there's 11-fold higher risk of getting infected if you're healthcare workers. And so that happened early on, and then later these numbers decrease because I think we learned to be more careful and take appropriate measures to prevent infections within the hospitals and within the healthcare workers themselves. But then there was, at the same time, in addition to just testing the healthcare workers, there's a need for widespread diagnosis and testing. And the reason why this was important, I'm sure you've heard this over and over again, that the reason we need this to be this frequent and extensive widespread testing, because the testing could trigger prompt treatment. We could identify and isolate the infected individuals. We can, at any particular time, calculate mortality, how many people are getting infected and how many of those die, so that we can know the extent of the virulence of the disease and the severity of the disease. We can survey how the disease has been spreading in the community, identify people who have been carrying the disease, because some of the people who do carry the virus do not show symptoms. We can actually even localize hotspots in the community where there might be some areas which are particularly high rates of the infection, and then later on we could then do that continuously so that we can track how the infection has been spreading, and then do some surveillance so that we would know what's happening in the community at any time and accordingly adjust our needs. So we have been actually doing all of that within our community. The Metro Health has been very proactive in providing as extensive a sampling and testing as they could. But those are primarily what we call convenience samples. People just show up and they get tested. So we would never have an idea of the extent of the disease in a community. And for that, we needed to do a randomized testing of our area so that we could know the true extent of the disease. And as you know, we in Jefferson County live in a slightly divided city, and we have different demographics across town. And we could see that there are areas which are predominantly white and areas that are not predominantly white. And so if we were going to test people, we wanted to ensure that we would include all those who belong to different, what we call zones of the city, so that we can get equal representation and participation. In its sampling approach, this is similar to what people do, for example, to get opinion polls or political polls. So what we did is we stratified the county into 4 major zones and then 2 subzones in each zone. And in this subsampling scheme, we could see there are different areas. The different areas have different percentages of non-whites and whites. And so in each area, we had to enrich our sampling for non-white population. So that was our first one stage, that it was stage 2 randomization. The stage 1 was the different areas of town. Stage 2 was the race. Stage 3, of course, the age, and then we had sex. So in each round, we can then attempt at least to include all the people of different demographics into the survey so we can get an understanding of the true extent of the infection. And this is not an easy task, because in order to get maybe around 2,000 people or 2,400 people, we had to send out at least 30,000 invitations. We selected randomly people around town and then invited them to participate in our community study. And hopefully some of you listening to this may have received some invitation in and have participated in the study. So am I still audible?
Yes, we
okay,
still hear you.
Yeah, there's some disturbance. Anyway, so then we invited people from all over the town. As you can see that there are people who distributed and lived in different areas of the town. Some people did want to get tested regardless of whether they were invited or not, and we couldn't turn anybody away. So we also tested people who we call the volunteers, we tested them because simply they wanted to get tested. So therefore, we have 2 sets of data sets. One is what we call the stratified participants or sort of randomized participants or probability sample, and the other one is a volunteer sample or the convenience sample. So we compare both those samples to see what the differences may be and how effective it is to be able to do a randomized sampling of a community rather than just have convenience sampling. So this is one of our sort of composite graphs, and it shows the rates of infection within Jefferson County computed on the basis of the randomized testing. And as you can see, that we started with low levels of the disease, and the actual incidence skyrocketed somewhere in December of 2020, and then there was a sharp decline, and in April or May, we thought that we were out of the woods, but now back again until September and October when last tested, we were again in the red zone. So we could see that for each particular incidence that there was a certain number of people who reported to be infected. For example, here we could see that there were in the public records that week 2,000 people were infected, but we thought from our estimates maybe 12,000 people may have been infected. And the same thing now, although we have gotten better and we can catch most people, we may still be missing 50% of the people by just doing or relying on data of convenience sampling. So if we do random sampling, we get a much higher number of people who are infected. Many of the people who came to our testing sites, which went up all over town, did not quite know that they were infected or they had, or even that whether they have had the virus. But we did test for their antibodies, and so we could know whether these individuals do indeed or have had indeed a past infection. And so we could look at the antibody positivity or serology, and we could see an increase in the number of people who have been who tested positive. And this was the ELISA that our colleagues at the Center for Predictive Medicine made, our homemade ELISA, which we finally got an FDA waiver to use, or the CDC waiver to use. And then we could see that even though at times the number of people who we thought were infected, maybe it's like 20,000 people by November 2020, the number was actually 45,000. So the extent of the disease, the number of infected individuals may have been twice as high as what we can tell from the public records. So we have continued testing that, but we can only do testing at discrete times, and we cannot continuously do that because we need to have different slices of time to be able to put the data together to develop a trajectory. And for that, we have developed this Bayesian model in which we could get the actual incidence as a continuous function, and we could see that we could predict the rates of the disease in our community over time till about the end of April here. At that time, we started receiving vaccinations in the community, and so many people have antibodies that actually are due to the vaccine, but not due to infection. The vaccine and the infection may both give rise to what we call IgG against the spike protein. But if the people who have had a natural infection, they also develop IgG against the nucleocapsid protein, and we call it the IgGN. And so we can distinguish acquired immunity because of the vaccine and immunity acquired because of the natural infection. But regardless, we're trying to figure out how to put the two data sets together, but our data before the introduction of the vaccine clearly shows a predictable trajectory so that we can at each instance calculate the rates of the disease and be able to then make other estimates such as differences in susceptibility, mortality, and so on, or even identify areas where the disease was prevalent. So as we can see that there are some from pre-existing disparities within our society, that different individuals have different disease risks. We know that they're for most of the chronic diseases. The Latinos are much more sensitive to diabetes, the African American population to stroke, Asian Americans and Pacific Islanders to liver cancer, and the American natives to heart disease and so on. So there are very wide disparities within our community, and when COVID spread, we saw similar disparities in population distribution, even though they were somewhat exaggerated. And so if you could see here that the actual rates of infection and disease were much higher, the cases were much higher in the African Americans than they were in the whites. And so that would mean that the disparities that we see with the chronic diseases translates into similar disparities in infectious diseases. So we tried to estimate what may be our local risk. And so what we found that people who were infected had a fatality infection ratio at that time of 1.3%. And these data do not include data from the nursing homes, because those were the confined facilities where we saw the highest rates of mortality. Whereas here we just actually sampled people who were living in what we call in open in the wild, rather than being constrained to nursing homes. We could estimate also that the fatality rate, infection ratio was 1%, which is actually consistent with all the other estimates elsewhere. And we found that the fatality rate in people who were non-white, so people of color, was actually twice as much as that present in the majority of the population. From this, as you can see from the map, we can also tell where the rates of infections were higher in different parts of the area. And if we look at the trajectory, we initially saw the infection increase in the East End, because I think there were lots of seeding events there because of how wide the higher rates of travel and so on and exposures. And then most of the infection for a long time was settled into the west end of the county. And then lately, this is from September this year, we could see that the southern areas of the town were infected. And this actually led to the idea that there may be different areas that are more susceptible to the infection. And this is the active infection, which was at that particular time. But overall, cumulatively, we could see that the area shown here in the dark blue is the one that maybe have had the most of the disease, and at that particular time could show some of the infections. But in that particular round. But we then put all the rounds together, this is what we see. We see that there are areas of increase of the infection rates throughout the county. These are areas A1, 2, 3, and 4. So you can see that there are similar trajectories everywhere, but the highest rates are always, and the highest rates of infection have been in the area 1, which is twice as what was rest of the county. So in summary, we could not only tell who was getting infected, but where, what were the age groups, what were the demographics, and at each particular round, we could have new data that we kept informing the city. We kept releasing our data to the public and as well as to the CDC. In the last part of the project, we did get funding from them to do all this work on testing as well as surveillance. And so we thought that it might also be, in addition to surveying things, to look at how many people were willing to take the vaccine when it became available. And to our surprise, we found a very high proportion of people who actually said they would take the vaccine. And this was because people who actually responded to a survey are most likely to be ones who are concerned about their health, who care about well-being, and so therefore they were much more willing to come forth. But given the standard error of this particular survey, which we have now at about 70% vaccination in the adult population, is very similar to the data that we have here. We ultimately will, I think, get there if we keep our message, and if we keep conveying the importance and the actual a critical need for everybody to get vaccinated. The important point that at that time was not so much about the number of people, but where would people like to get vaccinated, where would they like to get their vaccine, and so we got. Hello, hello.
Oh, keep going, Dr. Bhatnagar. I got it.
Okay, so then there may be certain areas that people prefer, and now since then we've been able to track where the most vaccination has been, and so we can provide the city with some information about areas that might be pockets of resistance to vaccination, and that maybe there are some demographics that need additional convincing, or that our message could be tailored to a specific group of people to enhance the overall acceptance of the vaccine within our community. But the important question from that which arose was, if you have this, are people developing sufficient amounts of antibody? And that's been the question for a long time, but when we started, that was an important question to us. So we looked at people who actually got vaccination, and in fact, we had a lot of people in our cohort who were vaccinated and who were at least one dose or were fully vaccinated. And what we found was the vaccination, the antibody response to the vaccination was actually pretty good. Less than 1% of the people with at least one dose failed to develop the antibodies, or we say they prove to be have vaccine failure. So we saw vaccine failure only 1% of the population with one dose, but when they're fully vaccinated, less than 0.6% of the total population showed vaccine failure. Which is not to say that everybody develops equal amounts of antibodies. It just means that some people are actually likely to be more sensitive to develop the antibody, but some people just simply fail to develop antibodies at all. So anyways, in addition to just looking at vaccination rates and infection rates by testing people, we thought that we did need another way of looking at the spread of the infection within our community. And even before COVID, we were working on what we call wastewater epidemiology. And this was to test for, in our case, we were interested in testing for exposure to air pollutants, use of drugs and sedatives and pharmaceuticals in a community by monitoring the wastewater. But when COVID hit, we thought that we could move beyond testing and use this approach to test the spread of infection within the community, because individual testing, while effective, can often fail to identify asymptomatic people, and sometimes it's difficult to get to the people because, as you know, we did a random survey and we invite 30,000 people, only 2,000 people respond, so there's already a bias in our sample set which we cannot rule out. So we thought that if you do individual testing, that will always going to be a limitation, and maybe by sort of anonymously measuring the levels of the virus within the community, that we might have a much better grasp at the extent of the infection. So what this really means is that we collect community wastewater, we collect the sample, we bring it to the lab, we do the PCR, just we do like with every blood sample that we get. We use the wastewater sample, and we can collect it from different parts of the town and then be able to measure the rates of infection and the instantaneous prevalence at that particular time. And when we started doing this, it was again very early in the pandemic, and we were trying to even hone in our measurement techniques. We tried to figure out who's going to measure it, how we're going to bring the sample to the lab, and so on. But we were encouraged from reports from elsewhere in the country, and this is a study from Yale, showing that if you see an increase in the coronavirus in the sewage, that usually precedes hospital cases. So we thought maybe it'll give us a couple of weeks worth of window to be able to warn our healthcare facilities that we have infections here. So there are of course some risks involved in measuring wastewater prevalence, because we didn't have standard methodology. Everybody was trying to harmonize national efforts. And some people don't have sewage, and we might not be able to reach them. But the risks far outweigh the benefits because we can measure these quite frequently. In fact, once or twice a week. We can then also look at what's happening to this infection, to rates of infection, without actually, running around, going to everyone in the community, testing them, writing them, invitation letters, and so on. And so, if we do this, we might be able to follow rates of infection not only during the pandemic but even beyond. So this is one way to actually keep a tab on the rates of infection in our community. And so we did that from Jefferson County. We have an old county which has a very archaic sewer system. Regardless, we identified some points of collection that would serve large parts of these zones that we had created for the city. And that we thought that if we can monitor these zones, that we can overlap our data from the wastewater with our data from the community. And so we can collect concurrent data so that each approach could validate the other. And so we are still in the process of doing that, but this approach of measuring community-wide spread of infection by sampling wastewater provides us some understanding of the rates of infection and their increase and decrease around our community. And I'll show you a couple of examples here. You can see that in time we can follow how the rates have increased and they have then decreased and they've increased. And so that is one way of looking at the population-wide spread of the disease. And other thing we can do with this is to look at the relative distribution across different parts of the town. And you can see that there was a peak here, then we had a little bit of a lull, and then we have been steadily increasing in our rates, and now they have been beginning to plummet again. We can identify different areas with different susceptibility, which parts of the town at which particular time would be important or would have the highest rates of infection, so that we can then guide or inform public policy or whatever public health measures need to be taken, or to identify some areas of higher susceptibility than others. But when we were doing all of this, we were also confronted with the problem that there was not only just one type of coronavirus, but we developed a whole range of new variants have cropped up, some homegrown and some imported from rest of the part of the world. And I'm sure you're familiar with all of these now. There is the UK variant, and there's one from northeast of the United States. There's a California variant, a Brazil variant. And then now we also have the Delta variant, and they have varying degrees of infectivity. There is also varying degrees of antibody vaccination efficiency to that. So we thought that since we were doing the wastewater analysis anyway, that we could then look for different variants around our county, and these are some of the initial results showing where the variants were most. This was from March this year, and then this is from September. And as you can see, that most of the variants in our community is the Delta variant, which came up after June as took over most places within the county, and it's continued to increase and spread and has stabilized and taken over most other variants. And so we could then identify the distribution of the Delta variants in different parts of the town, and so that we can keep a tab on where this variant was and how it was spreading, and whether it would in one day subside or not, so we can identify those rates of infection in different parts of town. We are continuing to do that. Since we sequence our virus here, this is with our group that has been in biochemistry doing sequencing, and the whole enterprise is orchestrated by Ted Smith and by Paul McKinney and Eric Roschkin, all of those people who have been working to make sure that we can catch variants where they are, and if new ones emerge, that we might not be caught off guard in detecting them. But measurement and identification and detection is something. How do we actually evaluate people who actually get the disease? We would like to know not only uh, who gets infected, but why. And so one way of doing what is to be able to be sensitive and alert to who's getting infected and follow them longitudinally. So we think that we could actually follow some of the people who got infected to see what's happening to them. Do they get reinfected again? Do they lose their immunity? We can develop our own data. I know there are lots of other groups around the world trying to answer these questions, but we should not be left behind. We should be equal participants in the dialogue. And so we should have our own data to look at what is happening to people who test positive. We can then look at what is the demographic and clinical picture of these individuals, what are the factors that actually contribute to that to their risk and so on. And we have collected a range of data over the last year from 8 to 10,000 people, and we are still in the process of analyzing all the data from that, and we continue to study them. One of the questions that is of interest to our group, particularly because of our affiliation with the American Heart Association, with our tobacco center, was what would smoking do to COVID? And again, there were lots of reports in the areas, and some good, some bad, and some ugly, but there were also a lack of a clear, standard, large-scale study. So we were collaborating with the American Heart Association. We did a multivariate analysis of the association between different characteristics and demographics of patients who were actually admitted to 122 participating hospitals around the country. And these hospitals are part of the COVID-19 registry of the American Heart Association. They have a wealth of data on COVID outcomes and treatment and drug efficacy and so on. So we pulled out data with smoking. In total, they have about 31,000 admissions in hospitals around the country, but we selected about 6,000 of those who were smokers and then matched them with the same sort of similar characteristics with non-smokers to see whether there is a risk of smoking and does smoking affect the outcomes of COVID infection and once you're hospitalized. There are actually some reports showing that smokers actually do have a lower risk of getting infected from COVID, and we have found similar results in our group. But we wanted to know what would happen if you were a smoker and you were actually admitted to a hospital for COVID. And so these are the final analysis of our data. As you can see, that in our both in our unadjusted analysis and adjusted analysis, the death rate was much higher among smokers, and the use of the ventilator was also much higher in people who smoked. And we did find that there was, some association with the race, although we couldn't say anything significant. But there was actually a greater risk if you had diabetes or chronic kidney disease, or you were on anticoagulant therapy. And this association shown over here as well, that in smokers, if you were of a younger age, you were at greater risk, and that if you, male and female, did not make a difference, but obesity did, and diabetes and hypertension, and these are classic risk factors that would actually mediate some of the higher risks that smokers might have in getting infected. So what this tells us that there are sort of pre-existing vulnerabilities in smokers that makes them or puts them at a higher risk of developing severe symptoms of COVID than individuals who do not smoke. So I think this would be helpful in trying to understand the role of smoking and how it modifies a disease. Maybe smoking has a different outcome than nicotine. And certainly, like I was saying, that nicotine may be immunosuppressive. And I know some colleagues of mine in France and other places doing clinical trials would say that maybe nicotine might be able to suppress immune responses, particularly the cytokine storm that accompanies COVID. And so that is grounds of further study. But the overall idea would be in these individuals is, do these pre-existing conditions affect response to vaccination? And I think that's an important question, and that's the most current important question we can think of right now. And how would that modify response to the vaccine? And although we couldn't tell the actual level of antibodies that people develop, we could actually get a yes or no answer from our data. And this is data from 5,000 people that we collected from April to August of this year. And we can tell at least whether somebody does or does not develop a response to the antibody or to the vaccination, sorry. And so that would be, we call vaccination failure or vaccination success. That's all we can distinguish. We do not know what the titers mean, although we have titers for some of the people that we tested, but there is no way to directly relate these titers to the risk of infection, but at least we can identify the most extreme cases. And so the data shown here, if you look at this carefully, this is antibody positive individuals, these are antibody negative individuals, and you can see that if people are do not have any pre-existing conditions, or we call chronic health conditions, that they are actually at a lower risk of vaccine failure. If they have a diabetes, that they get a much higher or a threefold greater risk of vaccine failure. And we see vaccine failures in people with hypertension and heart disease as well. But the most remarkable result was with autoimmune disease, where we saw an 11-fold increase in risk of vaccine failure if you had pre-existing autoimmune disease, and then chronic kidney disease, as well as people who were on immunosuppressants and anti-cancer drugs. And so although these outcomes and these medication reports are self-reported data, we think that this sort of at least underscores the idea that people who are immunocompromised are less likely to benefit from vaccine, and maybe there is a continuous distribution. But we think that people who are immunocompromised are likely to be most severely affected, and maybe rather than having indiscriminate boosters to everyone, that we could identify populations based on such analysis to figure out who or who should not be getting the booster, or whether some people would not even benefit from getting the booster at all. And so we can follow these people again and see even after booster they develop any response. And even though we have liberally advocated booster here, there are other countries that have less resources. This may be an important way to test. So in our multivariate analysis, we find that there is association between different clinical characteristics and the antibody negative status. Of course, if you have one chronic health condition, you have a twofold risk of vaccine failure, but if you have multiple, the risk multiplies. So the more chronic health conditions somebody reports, the more likely they have to have vaccine failure. So from this study, we sort of concluded that among the fully vaccinated individuals, if you have any healthcare conditions, don't have any chronic health conditions, you have much lower risk of vaccine failure, but you have any that you could develop vaccine failure, and especially people with chronic kidney disease, autoimmune disease, or people who are on immunosuppressive drugs and therapies. And then these risks add up. So I think there is much still to be done in this area. I think others are continuing to look at it, and we would continue to look at as well and see who is likely to have vaccine failure regardless of how many boosters that they might receive, or maybe if after some boosters there might be no difference. So that's something that remains to be studied. But in the final few minutes, I just want to indicate that we do want to continue looking at people who have COVID. As you know, COVID is a respiratory virus. It is caused by SARS-CoV-2. There is infection due to the binding to the ACE receptor, and the virus gets into the lung cells and other cells, but it doesn't stay there. It multiplies and develops lots of progeny. But it can also transform into a more significant disease. It starts off with infection of few pneumocytes, but then it goes and it elicits a very wide-scale inflammatory response, and sometimes it's the inflammatory response that causes more injury by leading to pulmonary edema and lung inflammation, but also effects on much peripheral sites, and a variety of different extrapulmonary manifestations of the virus have been reported. These range from neurological symptoms to dermatological, cardiac symptoms, as well as renal, hepatic, GI symptoms. And so the prevalence of these symptoms is actually shockingly high. About 87% people who recover from COVID actually report fatigue. And that may be only for a few weeks to months, but some people have really sustained levels of fatigue. A large number of people have cardiac dysfunction and myocardial inflammation and so on. And so we do not know that this we might feel as a horrible episode that may last a few months or years, but it may have lasting effects on the health of our population, and certainly something that we should and must follow and look at the data here locally and not just look to other places elsewhere and say, oh, so the data from X, Y, and Z places tell us that, where we are sitting here unaware of what's happening within our own community. So we need to clinically manage our complications. How do we do that? We need to actually keep a registry of the people who've had these cases. We've started a post-COVID clinic, or what we call the long haulers clinic with UofL. I think Norton has started another facility like that, and we must have the facility to come to talk to these people. From the reports that I've heard from Dr. Kaufman, who runs these clinics at the ACB, is that people are very grateful that somebody's hearing their concerns and complaints, because they might think that they are made to feel that they have these phantom pains that are not actually real, and that there must be something else wrong with them. But to have somebody pay attention to their symptoms, work with them, identify different approaches to be able to address the personal, sociological, and environmental needs of such people, that we would be able to grapple with earnestness the full spectrum of this horrid pandemic. So I'm going to close here and acknowledge the people who've actually done most of the work. Rachel Keith has been truly amazing, been out there in the community for each of these trials. I think also John Klein helped us. We have people with in the Center for Preventive Medicine, the team here who has been working diligently in trying to get a grasp on this. And we had funding from a group of people here within the community. When we first started, we had no means, no resources, but our generous donors and supporters from the community came forth, including foundations that supported our initial work. We got support from Metro, and then lately, though not listed here, we got generous support from the CDC, which came in this year in June. And so we will continue to work as long as we have funding and as long as there is need in our community to look at the rates of the infection among our community members, and also among different areas in the city, by using both randomized testing and wastewater analysis. So I will stop here and I will stop sharing and take any questions anyone would have.
All right. Thank you, Dr. Bhatnagar, for outstanding presentation as always. And we do, if anyone would like to ask a question, you can unmute your mic and ask. We do have some questions in the chat area, and I will go with them in a chronological order. The first was from Stanley Levinson. He wants to know what levels of cutoffs were used for the antibody tests. Was it possible to distinguish different levels of protection or percent likely protection?
We did not have an independent scale, nor does the CDC or the FDA, at what level of antibody titer or neutralizing ability is required for effective immunity. So we are very wary of interpreting our levels as such. What we did here was simply to use a cutoff of our assay and say we could detect a positive change at all or nothing. We know that this is in some way loosely related to the overall strength of the antibody, but this is a completely arbitrary cutoff, but it does indicate very low antibodies. So we want to remain saying that in our arbitrary scale, we think that these are low levels.
All right. And our next question, and she's on, so I don't know, Dr. Kruger, I can read it, or do you want to go ahead and ask him?
Aruni, first I'm going to say thank you very much, and I also want to chime in regarding Dr. Levinson's question about antibody titers. As you know, Loyola is using antibody titers in their healthcare workers to help determine when and if to give a booster, although you accurately pointed out that not all the variants are going to respond to the current FDA-approved vaccination, so that might become a bit of a conundrum. And people are trying to compare native infection and also vaccination as to which is better in terms of long-term immunity. And it looks like it turns out if you have native infection, because you have more than just antibodies to spike protein, you are probably better off. And why is this important? Because I love that you said it's 11% of healthcare, or 11 times fold increase was for healthcare workers. And obviously we don't want to infect our patients or our coworkers. So we have to know our immunity status is very important if we're going to remain employed. And this has become an issue, of course, or people who don't get vaccinated end up losing employment. And an issue I have with that is we still haven't figured out if you've had the active infection and recovered, do you still need to get the vaccination? So that's something that I think people really do need to talk about. My question is on these large cohort studies with the American Heart Association. They always look at chronic diseases. Why don't they look at vitamin D levels? I'm going to say that. You know I'm going to say
that. That's right. So the thing is okay, I'll start with the last question first. It's difficult to do any work. I mean, even when we went to the American Heart and said, can you ask smoking questions when you admit people to COVID? We got such a pushback. Say, we are saving lives, and to hell with your research, and don't come and talk to us. We can barely, get people admitted, and we don't sit there and ask questions about whether you smoke or don't smoke, or whether, whatever, how much income you have. But they were actually very good, and they at least got the smoking part in. But the other research has been very difficult to do. But you're right. I mean, we should be doing that as a susceptibility factor. We don't have samples from these people, and maybe we have to start another registry or an altogether different study. So that's the thing. Then the second issue about the vaccine is, so we don't really know what the vaccination levels mean. I think the titer is always very difficult to interpret. We were doing the neutralizing antibody levels, right? So that's the most important way to do this. And we could do it because we have facilities here to do. Most labs don't. Most places don't. But the issue is that you can do the neutralization against the alpha variant, and now you have the delta variant. So it's like a moving target to be able to figure out what to do. If you have a natural infection, you're going to have a much more general response, right? So you would be protected from the increase in the infection to begin with. What most people don't realize that the antibodies and the vaccines are IgG against S protein, right? They don't develop IgA. So you don't have IgA antibodies, so it wouldn't prevent the virus from landing in your nose and infecting your mucous membranes, because you're going to be infected regardless of whether you're vaccinated or not. The vaccination would prevent serious illness, and that's exactly what it's doing. It cannot prevent infections. And so now when you have a natural infection, you have IgG and IgA, and so you will have mucosal immunity, and so you would not get the infection. So of course, the getting a normal infection gives you much stronger immunity, but unless you have very severe disease, those antibodies can actually decay very rapidly too. So we found decay in several of our participants, and we don't think that just because you have an infection that you should not get an antibody. At least there was a study just last week that you get a 9-fold increase in immunity if you get a shot after you had the actual infection. So we still highly recommend that. But if we could, or maybe the CDC could, come out with a scale of what it means and how to interpret these titers, and then use them to guide the boosters, then it would be, I think, a step forward.
Otherwise, we're going to be probably boostering everybody, particularly healthcare workers, probably once a year, if not every 6 months until this thing goes away.
Right. Actually, the titers could tell us that. So if we keep measuring and we don't see a decay in the antibody titers, then I think we should be pretty sure that this is staying. So we would do this next year again and see what the staying power of the vaccines are.
Perfect.
All right. And our next question actually comes from Dr. Dinesh Kalra, and he wanted to know, if I scrolled the wrong way, says, are you planning on studying medium-term risk at 3 to 5 years for heart failure or MI in patients with prior COVID infection? That would be important data to have in our community.
Yes, so we are not doing here locally because I think we don't have a large enough cohort. And the hospitals that see people post-COVID clinic do not usually follow them up for the long term. But in the American Heart Association registry, we are following the people who would actually recovered from COVID. We have lots of deaths, of course, but there are lots of people who have recovered, and the COVID-19 registry is looking for both acute cardiovascular complications and long-term complications. So there are groups I know who are writing manuscripts from the COVID-19 AHA data to look at the percent distribution of different cardiovascular outcomes, particularly AFib, heart failure, cardiac inflammation, myocarditis, and so on, and then look at what will happen long-term, because certainly the question is whether if you have a cardiac involvement at the time of the infection, are you more likely to progress into frank heart failure or cardiac dysfunction later, or maybe you don't show signs before and these things develop later on. So yes, certainly we are following that very keenly.
All right. And
Gotcha. How many patients do you have in your registry?
So there are 30,000, not here, but the American Heart Registry that I work with, 30,000 patients. And of that, we have over 6,000, 8,000 deaths. So I think at least we'll have at the most 20,000 patients that will have long-term data. But we do have data for all 30,000 patients in their immediate involvement. On admission, what was their cardiac function? Or was there any cardiac involvement or not? In several cases, we have complete medication use and so on. We were trying to look at people who were on the thrombotic drugs, or antithrombotic drugs were actually more likely to die because they already had higher risk of thrombosis, and even with that they were much higher. So that's why they were much higher risk. We found that there was no greater risk with the ACE inhibitors and ARBs, that they were not much greater risk. We did have very high levels of cardiac involvement in the initial admission analysis, and also the people who actually eventually died also had high levels of cardiac involvement.
Great, thank you.
All right, Dr. Bhatnagar, a couple of more from, sorry, go ahead.
Dr. B, thank you very much for a nice talk. And one comment here about the immunity and the antibody titer. We are still in a big mess, even after 22 months of this pandemic. For example, the diseases like hepatitis B virus, the antibody level from 1 to 10 international units would protect an individual. And in case of rabies virus, even if you have 1 international unit of the antibody, would protect the person from the fatal disease. And there's a lot of unknowns. We are still in a gray area here, and hopefully, maybe through your work or people's working on this day and night would help us in basically cataloging the immunity level into it. The question,
Yes.
The question comes here. Although the world is still, struggling with this disease, and we are all lucky here who are, basically healthy and, still are doing okay. Although many of us, have direct or indirect people who have been affected and they probably, could not survive. The question comes here, the long-term, long hauler effect of these viral infections. No one knows, how to deal with the patients, whether they have brain kind of pathology and the cardiac implications, because people are starting saying it's like more a vascular disease, and a lot of ACE receptors are there on heart and Westwater.
Right.
Yeah. So
Right. So, yeah, you're very right. I mean, there is, of course, great need to actually follow people, and what happens in the long term, we don't really know, and we are going to learn as we go along. But the other problem also is that with the long haulers, whether it's going to be totally vascular a problem, we don't know. The most common symptom is mental fog, and the mental fog could be involvement of the brain, or it could be poor blood perfusion to the brain. We do not know that yet. There is a lot of reports of muscle fatigue and so on. So we are trying to understand that, and that's why we should and must have our own data here, and we're trying to do that. But also there are national databases that we are working with to make sure that we understand what's happening and learn from that.
Thank you.
Yep.
All right, Dr. Bhatnagar, two more from the chat area. One, Dr. Peter Hasselbacher wants to know, what is your best estimate of the percentage of Jefferson County residents who have had COVID infection overall, either symptomatic or asymptomatic to date?
Oh, so now you put me in a test there, but we have done all the analysis for our, I think, the overall range, and I think there were at least 15% or more people may have been infected, and I may be off a little bit from that, and we are still sort of accumulating it, but that's the number that we want to get at, is how many people have had this infection, and it's a large population.
All right, a question from Dr. Philip May. He wants to know, are adults with intellectual disabilities at greater risk of poor outcome from COVID-19 infection?
Well, we do not know whether there is a cerebral component in determining the risk and whether there is or not, but there could be some behavioral aspects that could put them at greater risk. But there isn't any neurological data that's saying with some neurological issues that people could be at greater risk. At least I'm not aware.
And one last question from Adil Khan wants to know, as we still have various misconception and disinformation spread all over the social and mainstream media, do we have any research in Continuum which would quantify the effects of the disinformation, or are we doing some work to counter that?
So we are not doing that sort of research, but I know others have and are doing. I know my colleagues are trying to sort of very closely follow what effect the disinformation is having on people and how we could best quantify that. So we need to know is to what extent the spread of certain things in the social media and so on have led to this. And because it's developing still, we do not really have very reliable figures. Now, are there attempts to counter that? I would say, unfortunately, not enough. We do need to have a much more vigorous counter response, which we have seen in some places, but not universally. There are people, of course, we in the healthcare profession would keep saying that, vaccines are great, we should do it, but we need actual reinforcements from people who are the movers and shakers and influencers in our community, and in some places, unfortunately, that's not been the case. And so those who are going to follow evidence and believe in the value of empirical work and evidence-based decision-making need to be somewhat more confident and active and vigorous in their views, and try to not just aggressively persuade people, but to be able to answer any of the concerns that people have. For example, most people say, well, I don't know, if I've already had infections, I don't need antibodies, or I don't need a vaccine. So that's what the data came out 2 days ago, showing it really does make a difference even when you've had the infection. Then the other people think, well, if I have had the vaccine, I should not get infected. Well, vaccines are not going to protect you from the infection. That was not the point. The point is that it protect you from becoming severely ill or to some extent infecting other people. So all those sorts of things, that those answers need to be there, and the scientific community and as well as the healthcare workers need to have a much more humble stance and more responsive to what the questions the community may have without a prejudgmental approach.
Solid science and rational thinking will take us out, sir.
Thank you. Yes, Chris,
So yeah, from a healthcare worker's perspective, we have to wait for you guys to produce this solid science while we're in the hospital, kind of flying in the dark. But I will tell you that it was quite an eye-opening in June and July when the Delta variant took effect in mainly young people who had not been vaccinated. And we were admitting to the hospital people who were not, COVID positive, not vaccinated. And they were the ones that got the sickest, got admitted to the hospital. Now, because they were younger and healthier than the prior spike, most of them, the death rate wasn't as high. But I think that was eye-opening to a lot of healthcare workers who then go out in their community and are proponents for the vaccination, because it's humbling to watch what's happening in front
Yes,
of you.
that's
and
right.
then wait for the studies to actually tell you what you already saw.
Right. But just one closing statement. We shouldn't oversell the vaccine either. We have to be careful. And there are risks involved. Some young people do develop, myocarditis and so on. And we cannot negate that, although we should add that things resolve very easily. But we do not know what the effects of one really severe inflammatory episode may have in the long term, right? Sometimes these severe episodes can break the blood-brain barrier forever, right? And so that if that breaches, then you have long-term problems. So that's why we should be careful with our boosters. We cannot indiscriminately just keep giving people vaccines and saying that they're innocuous, because they're not. But we are, clear-eyed rationalists, and we should know that there are risks involved and what's the benefit of taking the vaccine. So we just can't go all gung-ho and say, we found the solution and, you people are not listening to us. That's not the case. So the reality is somewhat in between. And that's the reason most people have little patience with scientists, because we always hedge our statements and say, maybe this is possible, that is possible. So there are no most times there's not definite answers, but at least we have a path forward. And I think that if we continue with mass vaccination, we will get through this. Also, this will go from pandemic to an endemic status. It'll be here with us for a long time. And so we will keep doing this and keep coming back and telling you what we are doing.
Thank you. Good job.
Thank you. All right, Jason, signing off.